Dr. Siddiqui was able to join us here.
Dr. Siddiqui, hi, how are you?
Hello.
I'm sorry,
Good.
I'm late, and I'm also sorry that I'm not there with you guys. Could have avoided if we have a big snowstorm coming in tonight, apparently.
That's what we hear. So thanks for joining the call. Appreciate you being here. So the setup was pretty simple, which is it seemed like a great opportunity during the VEITH symposium to revisit our initial KOL discussion back in March. Thought it would be a good opportunity just from the Inspire MD perspective to be able to present our thought leaders and leaders in the field. Maybe it would be just a good chance for you to sort of revisit that discussion several months ago and share any thoughts or updates relative to your point of view as it relates to evolving technology, market changes. You've obviously had the opportunity to use the CGuard in our ongoing CGuard trial, but just in general terms, I think this is intended to be an open discussion about the carotid space in general and where we see things evolving, and maybe make mention to some of the work that we're doing in the tandem area as well.
Well, the gods of carotid intervention are sitting in front of me, so I'm going to not do anything where I might run afoul of their expertise. So I'm going to sort of talk about an area which is near and dear to my heart, which I deal with on a regular basis, and that is truly symptomatic carotid disease. Honestly, a real stroke that comes in with a large vessel occlusion or with a medium vessel occlusion, but with an additional either carotid occlusion or a critical carotid stenosis, where you say, well, I probably should fix that before I go north. I don't want to leave that alone. And so in the symposium yesterday, where most of us were there was this discussion about how much you need to delay before you treat the carotid. And, you know, with tandem occlusions, there is no delay. You actually treat the carotid first and then deal with the stroke. And we have had just phenomenal results doing this for patients. And in the randomized trials that were done outside the US, where they did include these patients, there were 20 to 30% of large vessel occlusion. So these were big numbers. And so in all those instances, people were doing something to the carotid. There was a little bit of hodgepodge in those randomized trials. Some were just doing plasty, some were stenting, some were just plasting with the guide catheter going above. But what we have been systematically doing here in Buffalo is that when somebody comes in with a symptomatic carotid with a high enough NIH where the patient is in trouble, and I'll define that, NIH of 5 or 6. And then you've got to look at, is this carotid occluded? And if it's occluded and they have a perfusion deficit, even if they don't have a tandem occlusion. So this is those people who have an incompetent circular Willis. So these are people who are symptomatic with a carotid occlusion, NIH 6, 7, 8, 9, 10. Those are the ones that fall into a category where I think they should be stented. A second group is true tandem occlusions, where the carotid is occluded and the M1 is occluded on top of that. And then their third group is where the carotid is severely stenosed, typically 70, 80, 90%, and they have something distal intracranially, which needs to be fetched, M1, M2, M3. In all those categories, we have been systematically treating these patients with an upfront load with aspirin and ticagrelor. We have sort of moved away from Plavix for 2 reasons. One's because in the neuro space, we have a 20, 30% resistance, which results in thrombosis with intracranial stenting. So we just, by definition, because we do a lot more intracranial work, we just have moved to Brilinta, where the resistance is very rare. The other thing I like about Brilinta is that it's a 30-minute load, peak serum value. So I think that makes life a lot better than a 4-hour Plavix load. And we bring them up to the cath lab. We use a balloon guide in every single case, 8 French with a balloon guide. And we don't do a separate balloon for the external. And the reason we don't do that is we actually did a study. I think some session with some of you there where I actually shared that, where we have done about a dozen cases now. We do these Nova signal Dopplers on both sides, and the moment the balloon goes up, flows reverse intracranially without external occlusion. So what we do is we inflate the balloon after we do a roadmap, open the TUI, so we've got back bleeding. There is no concern for distal embolization at that point. Cross the lesion, plasty, stent, and then go up north. And in my mind, when I think about this, this is, you know, the most severe form of symptomatic carotid. And I wish we had the CGuard, because I believe that really would be the best stent in this acute state for two reasons. One, it's got a much lower metal surface area. So, you know, you think of other cover devices, you think of the Casper stent, it's got almost a 40% metal surface area. And we have had acute stent thromboses that have been reported because the need for dual antiplatelet therapy is so much higher for that stent. Scaffold is off the market at this point, so otherwise that probably would be reasonable as well. And so I really think that the CGuard stent with its fine plaque coverage, low metal surface area with less need for aggressive dual antiplatelet therapy, never have to give integralin, by the way, not once do we have we given 2B3S for carotids. Really is the best stent. So if you all would help me push Marvin so we can submit the IDE to the FDA, we're all gung-ho about it. I think that's what we need to do. And there is no competition there. There is no label there. I really feel that, you know, you all can really sort of lead the charge, and we all know about the national coverage decision. But I think stroke is a wide open space that will bring incredible value. And I honestly feel that this is the best stent because it allows to deal with tortuosity with its open cell design, and it allows to deal with plaque prolapse with the mesh. And I'll stop there.
Great. Well, thank you for that. And we're actually sending a contingent to Buffalo tomorrow. So you'll be happy to know that you don't have to push me. So we're coming quickly. We heard you loud and clear. And we think this application for CGuard is certainly one that we're very interested in and offers really an optimal scenario for the design that we put into the stent.